my knowledge, it is not known whether those effects are permanent or if they're reversible, but there have been some systematic reviews and kind of meta-analyses that show that over time that the patients that have been on these medications can suffer from confusion. And so that is an important aspect of these medications that needs to be discussed with patients.
Dr. Jepson, how effective are some of the non-drug treatments, yoga, physical therapy, acupuncture, bladder training, etc.?
So those, in the systematic review we performed, those were all shown to be very effective. The behavioral changes, behavioral modifications, timed voids, Kegel exercises, all of those essentially have minimal to no side effects. You go to the bathroom every 2 hours, and so that you empty your bladder before you'd have a leakage event, or you'd strengthen the pelvic muscles, and there are really minimal potential side effects to those interventions.
Are there ways for people to find professionals who can guide them in those non-drug approaches?
Certainly. I think that a lot of this can be done through your family practice doc or through your internist. Many of them are very comfortable and able to do this. There are specialists, either urologists or urogynecologists, that would be also very happy to see and to treat patients with these issues. One thing I was going to comment on, as far as the efficacy of the kind of the non-medical treatments, those have been shown to be effective, and they are effective. One of the things to consider when looking at the data for anticholinergic medications or some of the more advanced therapies, you mentioned acupuncture, which we call posterior tibial nerve stimulation. That's basically a TENS unit attached to the acupuncture needle. Patients have to have failed prior treatments before advancing to a medication and then advancing to something like PTNS. And so we tend to see the kind of the more refractory patients advancing. But certainly for any woman suffering from urinary incontinence, starting with these non-invasive or less invasive interventions, I think, would be advisable.
How effective are treatments? I mean, can a woman who is dealing with these rather embarrassing, sensitive issues, can she get successful treatment?
Yes. The short answer is yes, most definitely. And again, every woman is different, and so what I recommend to patients when I see them is let's start with the less invasive options. If that relieves your symptoms and improves symptoms, we don't need to proceed with more. One of the things to consider with these is these are quality of life issues, right? And that is not to say that they are not impactful. They are very impactful to a woman's life and can be quite debilitating. And many women choose not to leave the home or not to go out because they're afraid of accident episodes. But it is not cancer. It's not like something has to be done. And so when I'm counseling patients and discussing options with them, ultimately the decision is up to the woman as to how much or how little she wants to do. And some women, come in and they're completely bothered and want to do anything possible. And other women can come in and say, it really bothers me, but I'm just looking for some improvement so I can get back to such and such activity or not have to worry about things with when I go to the grocery store, but I'm not looking for complete continence. So it does very much depend on the woman and her individual goals.
Dr. Jepson, when someone has tried all of the non-drug approaches and done everything they can, including exercises and the pelvic floor strengthening that you mentioned, and then they end up in your office, what is sort of the last approach that you would recommend? What would work as sort of the ultimate solution to this problem?
So the answer to that depends on the type of incontinence that the woman is presenting with. If she has stress incontinence, which again is leaking with laughing, coughing, sneezing, the surgical options would involve a mesh sling, which is a narrow piece of mesh that goes underneath the urethra to offer support. Again, that is considered the gold standard by all national and international organizations, but it is a mesh procedure, and some women choose not to have mesh. Alternative options, there are sutures that can be placed in the pelvis. They go on either side of the urethra and lift and support the urethra to the back of the pubic bone. Another option would be to use to harvest tissue from a woman. So fascia, which is tissue that surrounds muscle, that can be taken from the lateral thigh or from the lower abdomen, and that can be used to fashion a kind of a native tissue sling. It's called a pubovaginal sling that would go underneath the urethra and bladder neck to offer support to prevent leakage. Again, based on the data would support the midurethral sling as providing the best long-term outcomes with the fewest complications. As far as overactive bladder or the urgency incontinence, kind of third-line treatments or surgical treatments for that, and not all of these are surgery, but the PTNS, the posterior tibial nerve stimulation that we talked about, that acupuncture needle with attached to electric current, that's considered a third-line treatment that has been shown to be effective. Interstim, which is basically a pacemaker for the bladder. It can be implanted in the posterior hip, and electric current modulates the nerves that go to the pelvis, and that has been shown to be helpful for overactive bladder. Or Botox can be injected into the bladder, and Botox decreases muscle spasms of the bladder and can help and decrease overactive bladder symptoms as well. So, I don't know that I think of those as like the ultimate, last step. I think of them as kind of a tiered approach, and you kind of, again, typically would recommend starting with less invasive therapies and kind of working our way up to these more advanced therapies, keeping in mind that patients who respond well to the initial therapies would not ever progress on to these more advanced therapies. And so the advanced therapies are effective, but we're also treating patients with more refractory or more difficult disease.
Dr. Peter Jepson, thanks very much for talking with us on the People's Pharmacy today.
Sure, it was my pleasure. Thank you for having me on.
You've been listening to Dr. Peter Jepson, Division Director of Urogynecology at the University of New Mexico. He's board-certified in both obstetrics and gynecology and female pelvic medicine and reconstructive surgery.
Earlier, we were listening to Dr. Chad Deal, head of the Center for Osteoporosis and Metabolic Bone Disease at the Cleveland Clinic. He was talking about gout.
We also spoke with Dr. Sarah Cosgrove. She's an infectious disease physician and the medical director of the Department of Antimicrobial Stewardship at the Johns Hopkins Hospital. She's also professor of medicine at the Johns Hopkins University School of Medicine.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
If you would like to purchase a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1172. The number 800-732-2334, or find it online at peoplespharmacy.com.
When you visit our site, you can share your thoughts about today's show. Tell us your story.
At peoplespharmacy.com, you can sign up for our free online newsletter or subscribe to the free podcast of the show. You'll never miss another episode. You can even share it with a friend.
When you sign up for the newsletter, you'll get our free e-guide to favorite home remedies. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks very much for listening, and please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.